I think that we will continue. Okay, so next speaker from Dr. Javed. Dr. Javed, I know you are connecting from Saudi Arabia. So you live in Fiji, don't you? Are you visiting Saudi Arabia now?
No, I am visiting Saudi Arabia as an executive consultant under a program of Government of Pakistan.
Oh, okay. So with speakers from the cold Boston and the hot Saudi Arabia simultaneously, I am feeling very strange. So in future cyber life, so I think we might have much strange situation rather than now. Okay, Dr. Javed Imran completed his MBBS at Allama Lakbal Medical College, Lahore in 1998. Then, after internship, he started his surgical residence at Jinnah Hospital, Lahore, and was certified as a surgeon by College of Physicians and Surgeons, Pakistan in April. Okay, receiving invitation from Fiji National University, now he accepted it as an opportunity to start endovascular surgery in South Pacific region, as well as academic activity as associate professor surgery for graduate and postgraduate teaching. Dr. Javed, please go ahead.
Are you able to see me?
Okay, please go ahead.
Okay. Bismillahirrahmanirrahim. I'm going to present this basic endovascular surgery. Why I choose this topic for the today's discussion? It's very important because I got the training in this special type of surgery from Arizona Heart Institute, USA, and in other parts of the world, this specialty is non-existent usually. Very few levels, the major tertiary care hospitals outside the US. So we can connect with our mentors to the e-health and discuss the cases with our parent institutes, especially the difficult cases, and this e-health can be helpful in this specific branch of medicine. So that's why I choose this topic of basic endovascular surgery for today's discussion. I understand everyone not maybe understand too much details of endovascular surgery. So if you are not able to, you may say, look comfortable with few slides, it's okay, but I will keep it generalized. Basically, it's a special branch of surgery which uses needles, wires, catheters, and sheaths as a basic stuff. But there are different types of interventions. We use balloons, stents, stent grafts, filters, thrombolytics, colloidal devices, IVUS mean intravascular ultrasound. Most of the people, they are well aware of this cardiac angiographies, angioplasties, but this branch involves all of extra cardiac vessels. In this branch, cardiac comes under the interventional cardiologist, and endovascular surgeon deal all vessels except the cardiac. So various type of instruments as shown in these pictures, endoluminal therapy, we go inside the vessels, offers less invasive approaches, thereby justifying intervention at earlier stages in the symptoms and disease complex. This is different than our approach to the medicine in the highly populated areas of the world like Asia, India, Pakistan, these areas. Patient comes with the symptoms and we diagnose and treat. But this is a different branch. We try to identify the disease and intervene at earliest stage. Similarly, when it started around in 1990s, 2 decades ago, it was not much sophisticated, and special, you may say, IT developments in last 2 decades, they have changed the face of this branch. So a lot of crude techniques, they have now become much sophisticated with the passage of time. And in this picture, you can see one balloon from left hand side, then a stent which is not covered, then a covered stent, and then different type of other instruments. These are the things which we are using over the passage of time. As soon as things are developed, new and new techniques are coming. And I wish to emphasize these techniques, they are not developed by the medical doctors always. Medical doctors, as a medical doctor, a surgeon, we just treat the patient and collect the data and present at various conferences. These are helped by our engineering colleagues who understand the characteristics of different metals, and also many other people who are just working as a supportive of the medical science. Of course, this is 21st century and we should go for new and new things. We cannot go with the traditional medicines of 200 years or 2000 years. So we have to change. We are the people on move. Modern treatment methods must accommodate our lifestyle. But this notion is much correct in North America and Western Europe. In the rest part of the world, which is highly populated like India, Pakistan, Bangladesh, China, these areas, still people are quite away from their basic health needs. So, one of the disease which commonly is treated by this technology is intermittent claudication. To simplify it, what is this disease? Absence of pain at rest, patients start walking, and then there is a tension of weakness. After walking has begun, intensification of condition until walking becomes impossible, and disappearance of the symptoms after a period of rest. So this is basically the leg pain in a common sense on walking, which is relieved by the rest. This is the most of the common disease, and then we do the angiographies. Angiography, you can understand, we put some dye in the vessel and take a traditional X-ray, and then these X-rays are more modified in a special machine called fluoroscopy, and then we can use advanced techniques as well. So laser, light amplification by stimulated emission of rays. It was a much more, you may say, exciting stuff which came, and we started using lasers and opening the vessels, which were being closed by the fat plaques with the passage of time. Interventional treatment should be reserved for the most symptomatic patients. Yes, this is a notion of 1998. Now it's 2015. Things may have changed. Laser therapy created excitement. Yes, laser was very easy to burn those plaques. Then they started heating those plaques, fat collections inside the vessel. But this is not much exciting, and so it failed. Then there was the idea that we should remove those plaques, and we started to use various instruments, and they were as good as the biopsy instruments. Initially, we started to take those plaques, but it placed the vessel wall as a naked, and again it started to produce more atheromas, and it started to create the trouble for the new atheroma formation. This is the single most breakthrough, that is putting a stent from the inside the vessel. We go inside the vessel, we dilate the channel, and then put a stent, a metallic material. So the vessel should remain open. Initially it was used by the iliac vessels, mean the vessels which are taking the blood to the lower legs, lower limbs. A second most common breakthrough is the shared stent for coronaries. Coronaries, everyone is well aware. Everywhere in the world, the people, they get this myocardial infarction, heart attacks, and then they go for this coronary stents. Overnight endoluminal approaches became the standard of practice in many arterial distribution, because the open surgery was always a complication, and when the patient finds it is very exciting thing and done very limited anesthesia, better outcome. So overnight, where people can afford it, it became, you may say, standard of practice. Where we can use it outside the heart, I'm stressing again and again, heart remains with the cardiologist, especially the interventional cardiologist. Rest of the vessels like here, the vessels which are supplying the blood to the upper arm, subclavian vessel, then to the kidneys, renal vessel, ileus, to the lower legs, aorta, the main vessel of the body, SFA in the anterior thigh, below knee vessels, popliteal vessels. All these things we can use in those vessels to open the channels. But always these things are associated with some troubles. What was the trouble? Because there is some foreign body made up of metal inside the vessel. So the major issue was restenosis and then instant restenosis. So we have to again and again intervene. For this reason, people started thinking, they started to understand the characteristics of the different metals, to change the metal characteristics, and then to load them with the materials or drugs which can prevent this restenosis, like heparin, certain antibiotics they used. Researchers are seeking the solution. They started using a cutting balloon. that we should open and cut atheroma. That was being used the cutting balloon. Then there is a drug called heparin. So it is for the prevention of this atheroma formation. It was being used, but clinically it did not show any much benefit. So they came towards the naturally occurring antibiotics, actinomycin D, but this trial was halted due to certain reasons. Then they came towards this sirolimus. It is various names of antibiotics, and they were using these things to load these stents. But basically, as a medical doctor, the technical details of these things, they are beyond our scope, and it is done by the engineers, and we are the people who just use them. But still we are getting this balanced effect, inhibition of restenosis and healing of stented vessel. This should be balanced so that we can get the clinical benefits. Investigations are extending into the peripheral circulation. Wherever we start this endovascular surgery as a new thing, we go with the peripheral vascular surgery rather than just starting at the carotids, abdominal aorta, and major vessels. So we start with the surgery to the legs, and there we can see, we can put the stent, we can put the graft, and then multiple technology can be applied in a single patient even. It's a very good system, silver hawk system. It was developed to basically remove the atheroma, and it removed the very big atheromas. You can see in the picture, atheroma is mean that collection of this fat inside the vessel, to simplify the stuff. Then the cryoplasty, cool laser, different types of techniques they were used, but this was limited to the small vessels, especially in peripheral vascular surgery. There is one more important thing, like the aneurysms of the great vessels, like thoracic aorta, the big thoracic aortic vessel, and the abdominal aorta. This was our traditional side. We were working like, you may say, putting the new grafts inside the body, major surgeries, and mostly the outcome was not good. Patient has to remain for the long time in ICU, and this was our traditional approaches. But with the passage of time, various companies like Medtronic, Endologics, Go, Cook, all help in developing these different types of stents. So now we don't have to make such a big incisions and open it up. We have to just go with this inside the vessel and put these stents, and they exclude those dilated portions of the aneurysm. So this is the traditional incision that you can see in this picture. It was a very big incision in the old times when we used to open it up. Sometimes we have to do, if we are failed in this endologics technique, then we can use this one. And then there are some difficult anatomies where we can't put the stents, then we go with the open techniques. So with the, as a coming to my conclusion of this presentation, I can suggest that with the use of this e-health techniques, we can extend these technologies and all these discussions to areas where experts are not available, especially outside the United States and Western Europe. If we wish to discuss these cases, whether the countries wish to use the technologies, wish to communicate with the companies who are producing these different types of stents and other interventions, we can go ahead with the use of this technology and help in the better outcome of our patient. Thank you very much for your patience.
Thank you.
Any questions?
Thank you. Okay, thank you, Javed. Are there any questions from here or from speakers? Okay, so thank you, Javed, for your participation, even though very big time difference. So due to the time limitations, we will move the next speaker. Thank you
Yes,
again,
sure.
Dr. Javed.